My job should have been after Gansham because he's going to be the master of offloading for the day. Any which ways, given the chance, I will go ahead with talking to you about in 8 minutes about what as surgeons we do to treat. So all of us know from the previous lecture and the first lecture as well that the formation of the foot ulcer is the beginning of the end. We heard that the IDF is urging people to practitioners to catch that window as early as possible and take all preventive measures to see that that pre-ulcer doesn't progress to the ulcer and the ulcer doesn't progress to infection, necrosis, gangrene, or even recurrent ulcers. So we need to break this chain as early as possible. So areas of high pressure in the plantar weight bearing surface or high pressure zones are called calluses. Patient continues to walk, gives daily repetitive pressure shear forces, leads to the neuropathic ulcer that breaks from within. Patient continues to walk in the absence of their sensation, continues to walk, many a time unprotected, fails to heal, infection, part of the foot amputated, recurrent foot has a remnant foot change. So this is basically a biomechanical problem that needs to be corrected. Anything that you do to relieve areas of elevated high pressure is called offloading. Your strategy is to basically reduce the pressure, get the ulcer to heal, and prevent the ulcer from recurring. It forms a very important component of the 6 tenets of diabetic foot. Any diabetic foot patient should have mechanical control or the offloading, wound control, wound dressing, microbiological control, take care of the infection, vascular control, making enough blood supply is there in the wound to heal, overall diabetic management and lipid management, metabolic management of the patient, and educating the patient to take care of their feet for a lifetime. This is the world follows what is the largest guideline on diabetic foot practice or largest evidence base we have is the IWGDF 2023 guideline. A lot of this chart is unreadable, so I'll make it readable for you. Basically, total contact cast is the gold standard. Other knee-high devices are the second. That's the gold medal. The silver medal is for various shoe modifications, and the other options like a couple of felt offloading and other measures, which Dr. Ghanshyam will talk in detail of all these 3 medals. My thing is not numbered. I'm outside the list, surgical offloading measures. So what does the question that IWGDF asked is, does a person with diabetes and a plantar forefoot or a midfoot ulcer, should he be offered any surgical offloading intervention over the non-surgical interventions? And the answer to that question is yes, because if you don't treat these recurrent ulcers and pressures through those conservative measures and they don't heal, then you need to resort to what is called surgical offloading. So my job is to talk to you about those 2 small boxes that the arrows are showing. I'm sorry about this, but again, the key recommendations will come. So any surgical procedure or technique undertaken with the intention to relieve the mechanical stress from a specific region of the foot includes Achilles tendon lengthening, metatarsal head resection, single or multiple pan metatarsal head excisions, distal metatarsal osteotomies, joint arthroplasties, arthrodesis, osteectomy, exostectomies. These are all surgeries done to relieve pressure. So what the IWGDF basically comes out with 4 recommendations with regards to surgical offloading in a person with diabetes, a plantar metatarsal head ulcer for which conservative measure has failed, an Achilles tendon lengthening or the correction of the gastric soleus changes that happen because of the advanced diabetic neuropathy, in addition to a offloading device. Recommendation 5B would be in metatarsal head resection, in neuropathic plantar metatarsal head ulcers for which again conservative measures fail, metatarsal head resection in combination with an offloading device. So metatarsal head resections and pan metatarsal head resections. So isolated 5th pan metatarsal head excision for a 5th MTH, or you can do for large central plantar ulcers. This is a sub-third after losing 2 toes. You can see a subluxated 3rd metatarsal head. A very simple dorsal incision which hardly can be made out in the post-op period. Excise that 3rd metatarsal head, isolated metatarsal head resection. This lady, a pan metatarsal head excision. After losing 2 toes, she had that recurrent ulcer. And after losing 2 toes, she had a very small, she had a pan metatarsal head excision, which is removal of all the metatarsal heads. You can see predictable healing. This is after the patient has been given 2 years of conservative management when they fail to heal surgery. And these corrective surgical offloading measures often fall into what is called the class 2 and the class 3 surgeries. The class 3 namely where there is an open wound, and the class 2 prophylactic where you have a pre-ulcer. There's no ulcer there. It's only a pre-ulcer stage. Recommendation 5C for HALX IP joint ulcer, which is the commonest ulcer. One of the commonest sites for diabetic neuropathic ulcer is the tropic IP joint of the first toe. You treat it with what is called a Keller arthroplasty, as you could see here. The Keller arthroplasty was done, and predictably you can see for long term, the advantage of surgical offloading measures is the recurrence is prevented for a longer period of time than the conservative measures. So again, multiple papers which support the use of these surgical methods to heal. And recommendation 6 is for apical digital ulcers of the lesser toes, that is the second to the fifth toe, secondary to a claw deformity, which is flexible deformity of the claw. To promote, you do a flexor tenotomy, which is usually done in the outpatient diabetic foot clinic. So that's how the third toe, you can see a claw deformity, underwent a simple needle tenotomy, flexor tenotomy, and you can see in 2 weeks it almost cannot be made out that the patient had surgery at all. But make sure there's no infection and there's no ischemia before, or you correct the ischemia before you attempt surgical offloading measures. Patients with diabetes and metatarsal head ulcers, second to fifth, lesser metatarsal head ulcers, where non-surgical measures fail, consider metatarsal osteotomies or metatarsal head resections, as we discussed. Try and maintain that metatarsal parabola when you treat them surgically. This patient comes with a recurrent callus and clawing of the toes, hammering of the toes. You can see that his patient had underwent a interphalangeal joint arthroplasty and a cava fixation. And then you can see that the ulcer heals completely and remains recurrent free. Patient who was skin grafted, obvious, very obvious to, I hope everybody sitting in this hall, it's a Charcot midfoot rocker bottom deformity. Skin graft failed because the underlying pathology was the bony exostosis. Exostectomy is the simplest surgical thing you can do for a Charcot foot, get the ulcer healed before the sutures. The other things is you can do 1-stage or 2-stage reconstruction of the Charcot foot, which again should be included as surgical offloading measures, because unless you do that surgical offloading, the callus there or the ulcer there in the medial midfoot will not heal. The patient was treated by internal rigid fixation, long segment. Patient with open ulcer and a frank osteo and septic arthritis subtalar, temporary 2-stage reconstruction. This is stage 1 where the subtalar is prepared, all the infected necrosed Charcot bone removed, temporary fixation, stimulant bead placement. Stimulant is basically long-term antibiotic bead placement into the wound, and then a final reconstruction which will lead to ulcer healing, as you can see there. So we should, like the IDF urges all people doing diabetic foot, urge you to break this chain of events to the left. The earlier you break the chain towards the left, the better is it for all our diabetic folks. If you don't offload your diabetic patient, your patient will walk to death, like my previous speaker mentioned. Total contact cast and irremovable devices are the gold standard. Choose your modalities based on the individual patient's necessity. Surgery has assumed a very important role over the last 2 to 3 decades. Calculated risks are there, as these patients do have neuroischemia, or you may make sure that there's enough blood supply to heal, and they have a lot of metabolic disturbance. So calculated risk, you will have to outweigh which is better. And sometimes early decision to surgical offloading can obviate months of conservative treatment failure. Thank you.